We are live, sir. Over to you.
Friends, good evening to everyone and a very warm welcome to the Oncology Masterclass. At the very outset, I thank Rajesh and his organization, Mice Ideas, Nirav from his organization for putting up a wonderful program. And not only that, popularizing this program to the extent that we have 300 plus registrations for this program, which speaks volumes about the efforts behind that. I thank all the faculty, the participants for taking out time. The format for these educational series is that we would be, in the first one, we would be talking about the presentations from the recently held ASCO meeting. And today we have an interesting program whereby we would be discussing about the presentations made on the various topics, starting with some of the developmental therapeutics on lung, breast, head and neck, and GU cancers. All this effort has been possible by the generous support and perseverance and the idea by Mr. Om from Samarth Pharmaceuticals. I thank him and his organization for the wonderful opportunity given to us. Without further ado, I would be doing the first presentation, and that is on the developmental therapeutics. Rajesh, somebody has to stop the screen. Okay, let me do that. And yeah. Are my slides visible?
Yes, sir.
So, as I said, these presentations actually are the highlights of the day, which happens every day in the ASCO program in the morning. And the first presentation, as I said, is the developmental therapeutics and molecularly targeted agents and tumor biology. Now, these are all very early stage developmental therapeutic molecules. And I would be discussing about the four of them. And the first one is the small molecule PC14586. The second one is this is a monoclonal antibody for the NRG fusions. And the third one again is a small molecule for advanced renal cell carcinoma, ovarian carcinomas, and then followed by lastly the bispecific ligand drug conjugate. Very interesting developmental molecules, and then hope that these see the light of the tunnel and they become frontline treatments over the years. The first presentation is actually about the first in human study of PC14586, a small molecule structural corrector of the Y220C mutant P53. Friends, we know that P53 has a pivotal role in the body's defense against cancer. P53 is the protector of the genome. It makes sure that the cells meet their endpoint of apoptosis over a self-regulated or a tightly regulated program. And P53 leads to the apoptosis, cell cycle arrest, and senescence, and thereby it protects the genome from any aberrations. P53 is self-regulated, and there is actually a loop with the MDM2, which has a very funny, in fact, the sort of a name which is derived from the mouse. Actually, one of the developmental minute 2 gene, and this makes sure that the P53 also is tightly regulated. But if there is a mutation in the P53, this may lead to inactivation of the P53, and which becomes an oncogenic driver. And this is actually called as the minute double mouse 2 gene. Now, this aberration Y220C in the TP53 is seen in about 1% of all these solid tumors, and dominantly amongst them are the ovarian, prostate, colorectal, gastric, most of the solid tumors we deal on a day-to-day basis. This is a molecule which is a reactivator of the P53 so that it corrects the abnormality which sets in because of this mutation. And The development has been over a period of time, and the typical phase 1 developmental process that small cohorts of 3 to 4 patients with dose escalation starting from 150 going all the way up to 1,500 milligrams twice a day, and that has been taken as the dose for the next developmental expansion cohort. And these are the patients, typically phase 1, 41 patients. Median age is 62, majority women, and majority again Caucasians in the trial. And the tumor types are listed out here. Ovary, pancreas, and breast actually are the dominant, followed by prostate and colon. The major side effects, the treatment-related adverse events have been nausea, vomiting, and some transaminitis. But overall, it's a well-tolerated program, and maximum MTD is reached at about 1,500 milligrams. And one can see the responses even in these patients who have been very heavily pretreated, and some of these patients have had 9 lines of previous treatment, and then they still showed some responses. Of course, as would happen in early developmental phase, everybody would not respond, but the proof of the concept is that there are responses as shown in the waterfall plot. And some of these patients have been on treatment for quite some time. And these are the patients who have had a higher dose of about 1,000 plus milligrams. And one can see some of these patients being on treatment for 9 months and beyond as well. Some small cell carcinoma patients showing rapid responses. The CT images showing out here some rapid responses. So the drug is effective. And the good news is that there is a synchrony with the anti-PD-1 in the preclinical setting. This is the curve which shows that the top one is the combination of the experimental molecule with anti-PD-1. And so that throws up some interesting profile for further developmental phase. And the conclusions from this study have been that there is a acceptable safety profile and some responses seen across solid tumor types harboring the TP53Y220C mutation. The second study is the initial efficacy and safety of seribantumab in solid tumors harboring the NRG fusion. Now, NRG fusions again are seen in about 1% of the patients, slightly maybe lower than that. And there are a variety of solid organs actually exhibit these. And the target through which these fusion proteins bind and activate are the HER3, which is interesting. Actually, in the fusions, there is no change in the structure of the DNA sequence. It's only the location of the gene which changes because there is a break from one, the fusion happens in another area, and therefore this becomes an activating and a predictive marker and a predictive biomarker for the response to some of these anti-NRG molecules. So one can see that there are responses seen with this molecule, and the trial was a simple single-arm phase 2, typical phase 2 study with seribantumab 3 milligrams IV Q weekly, a cohort of about 55 patients, and the overall response endpoint. There are responses as far as the concern. Fatigue and rash are the common side effects. And in fact, DLT is the grade 2 fatigue and some transaminitis as well. Now, because there is a fusion and there is a partner gene, so one sees there that there are responses, and this, apart from the whatever is the fusion partner in the NRG gene, despite that the responses are seen. So the partner doesn't matter. It's the NRG fusion partner, which is the NRG fusion is the one which is responsible. Again, some patients actually exhibiting and being on treatment for quite some time, beyond a year as well. And these are, as we know, heavily pre-treated patients, and some adenocarcinomas also showing responses as shown on the CT scans. Now, there are more monoclonal antibodies in the same category of drugs. And one can see that there are the grade 3 reactions to seribantumab versus zenocituzumab, and these are grade 3 and grade 4 are actually far and few, therefore giving it a very good safety profile. So there is an activity in non-small cell carcinoma with the NRG fusion gene. This is an unmet medical need in medical science. There are no interventions today available, and hopefully this should progress further to a phase 3 trial. The third presentation of the day is again a phase 1 and first in human study of the DS600A in subjects with advanced renal carcinoma and ovarian carcinoma. This is the expression of the CDH. This is actually a CDH6 inhibitor. CDH actually comes from the cadherin family, superfamily actually. We know that there are many cadherins, and these are transmembrane structures which have a dominant extra membrane outside of the membrane expression and a small intracellular transmembrane tail, and this molecule actually inhibits the CDH6. Again, the developmental phase, incremental doses, and the developmental expansion happening at about 8 milligrams per kg body weight for RCC and ovarian cancer, because these are the ones which are exhibiting the CDH6 expression. So again, good safety profile, though there are some treatment-related grade 3 and beyond in about 20-23% of these patients. Nausea, fatigue, and vomiting, again, these are the major side effects. And the DLT happening at about 9.6, therefore one dose below that was the 8 milligrams, which was chosen for the clinical development. Again, the responses one can see out here. Again, these are very heavily pretreated patients. Most of them ovarians were platinum refractory, and they had at least about 3 lines of therapies. And one of the ovarian cancer patients responding well and continuing treatment beyond about 36 weeks. Again, this molecule is generally well tolerated, and the dose, as I said, is 8 milligrams, and early clinical signals are there. So we're hoping that this molecule proceeds further. The last and an interesting is the bispecific ligand drug conjugate in patients with advanced solid tumors, again a phase 1A, 1B study. And that's the structure. There are the 2 limbs to it, the folate receptor alpha ligand targeting the moiety, and the other one is the calcium channel TRPV6 targeting moiety. And we are very familiar with the auristatin the monomethyl auristatin, which is also one of the payloads in brentuximab, and so we are quite familiar with this. So this is a cytotoxic drug which is responsible for the final mechanism of action, and being a cytotoxic drug, the side effect profile is again, and then that shows the incremental doses for the development and getting to know the MTD. So 0.17 milligram per kg body weight or 0.15 milligram body weight. And being a cytotoxic payload, so there is a myelosuppression which is associated with this, and some transaminitis and nausea, vomiting, which are associated being a typical cytotoxic agent. One can see the responses in the platinum-resistant ovarian cancers. And again, the folate receptor alpha expression has been studied beyond a certain cutoff, and one can see the responses happening in a greater percentage of these patients because the drug is designed in a manner to target the folate receptor alpha. So again, the toxicity is manageable. There are no treatment-related deaths, and there is a neutropenia as already depicted and already pointed out, because there is a cytotoxic payload. No neutropenic fevers reported, and LFT's derangements were to the tune of about 50 to 70%. So one hopes that this drug also finds a rational endpoint as far as the further developmental phase is concerned. With that, I come to the end of my presentation. Thank you for your patient listening and your participation, taking out time this evening. And I hope the participants and everybody, the faculty, everybody will have a great interaction, great learning experience, and we hope to see you soon on one of these programs again. With that, I stop sharing my slides and hand over the proceedings to Priyanshi Sharma to take over from here. Over to you, Priyanshi. Thank you so much once again.
Thank you so much, Dr. Ashok Vaid, for such an amazing session. Now, further, I would like to invite Dr. Sumeet Goyal to present advances in head and neck cancer track. Dr. Sumeet Goyal is Senior Consultant, Department of Medical Oncology in Rajiv Gandhi Cancer Institute. Thank you. Over to you, sir.
Good evening, everyone. Hope I'm audible and my slides are visible. First of all, I would like to thank Dr. Ashok Vaid, sir, for giving me this opportunity today. And as sir said, these are brief abstracts taken from ASCO 22, which has happened recently. And we will be discussing topics which are relevant to us and may have use in coming days in our day-to-day practice. So I will be speaking on head and neck cancer, day 1 track. So I'll be presenting few selected abstracts from the day 1 head and neck cancer. This was presented there by Dr. Linian SCU. And there are 2 studies were presented, which said either chemosparing or schedule adjusting studies were there. So these 2 studies we have selected to see that aim to reduce toxicity, either by removing chemotherapy or by reducing the peak effects to the chemotherapy schedule alteration. So the first study was abstract 6000, which was presented by Ma et al. It compared radiotherapy alone versus chemoradiation in low-risk nasopharyngeal cancer. This was a randomized, non-inferiority, open-label, multicentric phase 3 study. So the patients who had nasopharyngeal cancer, either stage 2, either node positive but early T1, T2, and T3 and 0 were taken. So any lymph node, cervical lymph node, which had diameter more than 3 centimeters was excluded. Level 4 nodes were excluded. Presence of extranodal radiological ELE was excluded. And the patients with DNA copies more than 4,000 were excluded. So they were randomized either to receive IMRT alone or to receive IMRT along with concurrent cisplatin. The dose that they have used here is 100 milligram per square meter, 3 cycles every 21 days. So the primary endpoint was 3-year failure-free survival. So the second study was by Dr. Atul Sharma et al., abstract number 6004. Sir had compared high-dose cisplatin Q3 weekly versus low-dose weekly cisplatin plus radiotherapy. We, in our part of the country, and mostly we use weekly cisplatin for a number of reasons. So he has presented his data. This was again a randomized, non-inferiority, open-label, multicentric phase 3 study with the name of CONCERT. So again, patients with locally advanced, that is stage 3, 4A, 4B, locally advanced head and neck squamous cell cancers of oral cavity, oropharynx, larynx, and hypopharynx were taken of age group 18 to 70 years, 0 to 2, and they need to be cisplatin eligible. Again, they were randomized to receive either RT. RT was either 2D cobalt or IMRT, which reflect the practices across our nation. So, and cisplatin again was 2 doses were randomized, 40 milligram per square meter for 7 weeks versus 3 doses of 100 milligram per square meter every 21 days. So the primary endpoint was 2-year local regional control. So either they had used 2D cobalt or IMRT VMAT. So in this study, basically both the studies by Ma et al. And by Dr. Sharma et al., they had non-inferiority was declared if the upper boundary of the 95% confidence interval for the difference in 3-year or 2-year failure-free survival was not more than 10%. So it was 3 years in Ma et al. Study and 2 years in the Dr. Sharma et al. Study. Then they had 80% power to detect 5% one-sided type 1 alpha error. So both the studies, they demonstrated predefined non-inferiority. In the Ma et al. Study, the 3-year failure-free survival in the chemoradiation arm was 91.9% as compared to radiotherapy alone, where it was 90.6%. There was difference of minus 1.3%, and which was very well in the confidence intervals pre-specified. The p-value was again significant. So we can see here, yes, there was advantage of this study as shown here. So in Dr. Sharma's study, at 2-year local regional control, in the high dose cisplatin arm, it was 56.39%, whereas low dose cisplatin weekly arm, it was 60.9%, and there was difference of 4.51%, again within the pre-specified range. So if we look closely, the median follow-up was 46 months in Ma et al. Study, and the 3-year OS was in the RT versus chemoradiation arm was almost similar, 98.2% versus 98.6%. So whether we can omit RT in this subgroup, we need to know. And in Dr. Sharma's study, the median follow was 25.7 months, and median OS in the high dose cisplatin arm was 30 months, whereas in the low dose weekly cisplatin was 25.5 months. So by this, so they have shown probably it is non-inferior, but and this is the study which is ongoing and recruiting. Probably this is a study which is likely to answer most of the questions that these studies have tried to answer. So again, we need to wait for this, the results of this study to come to confirm whether the observations made in previous 2 studies, they hold good when a bigger number of patients are taken. So the criticisms were this, what they say about these studies. So what are the value implications based on balance of clinical activity, toxicity, and cost? So we know for sure acute toxicity results, the favor chemosparing arm in both the studies, and weekly cisplatin arm in Dr. Sharma's study. But this is not surprising. We all know reducing the dose or taking away chemotherapy arm definitely will result in less of toxicity. So are these studies practice changing? Both non-inferiority studies had limited sample size, large non-inferiority margins, and used non-OS endpoints. They had used local regional control and failure-free survival. So that's why they are saying we need to cross-check, we need to replicate these studies in a bigger platform and to see. And for nasopharyngeal carcinoma, possible for lowest risk group, but also would want to see mature OS data. We need to understand who should not get chemotherapy in this low risk group. And for Dr. Sharma et al., the comments were weekly cisplatin is used in practice by many as standard of care, especially in patients who are likely to not likely to tolerate 3 weekly cisplatin. So again, the previous study, which is recruiting, will be the definitive study powered to address the weekly versus 3 weekly answer. So again, 2 studies, the chemo additive studies. In these studies, they have tried to add either nimotuzumab or immune checkpoint blockade pembro to definitive chemoradiation. The first study, abstract 6001 by Sun et al., they have tried to add nimotuzumab to chemoradiation in locally advanced nasopharyngeal cancer. Again, a randomized placebo-controlled multicentric phase 3 study was there. And they have taken patients the same, KPS more than 70%, stage 3 to 4A nasopharyngeal cancer, and randomized into 3-to-1 randomization done, and 362 versus 121 were the patients. The chemotherapy arm was the same, cisplatin 3 weekly, plus or minus nimotuzumab was used. So here was their OS and disease recurrence rates. So in the nimotuzumab arm, they have shown the 5-year OS in the intent to treat population was 76.9% and 64.3% in the placebo arm. So p-value was significant, and the 5-year DFS they have shown to be 40.9% as compared to 14.4% in the placebo arm. Again, there was benefit at 3 years and 3-year loco-regional recurrence-free survival and 3 years distant metastasis-free survival. So, but the follow-up issues they have tried to show in this study that the loco-regional recurrence-free survival, if we look closely, there was no much changes, both in the terms of loco-regional recurrence-free survival and distant metastasis-free survival rates, because the curves are merging or seems to be close together. But however, what is not matching is this. There is a sharp decline in the DFS from year 3 to year 5. But here, no such difference here, but definitely some differences occurred here. So which was not explained. So where is this progression? So no difference when IMRT is given. So they had used two types of radiation. One was the IMRT, the other was 3D RT. So the authors concluded if the IMRT was given, there was no OFS differences were there. But when the 3D RT was given, the combination arm was better. So this is the second study which compared Pembro in combination with chemoradiation arm. This was presented by Klump et al. Abstract 6007. So it was in intermediate or high risk locally advanced squamous cell cancer. This was randomized phase 2 study. So they had used stage 3, 4B, intermediate or high risk patients, oropharyngeal oral cancers, hypopharyngeal larynx or primary unknown, ECOG of 0 to 1, after biopsy, randomized. So they had two arms. One, it was used in sequential way. Second, it was initiated upfront, then started with radiation and weekly cisplatin. The 7-week cisplatin was given in both the arms. The cisplatin dose that was used was 40 milligram per square meter per week for 7 doses. And Pembro, they have tried to give 200 milligram 3 weekly for 8 doses. And accordingly, they have tried to collect biomarker data at respective intervals. So they had compared both in the concurrent and the sequential arms at 1 year, 2 year, and 3 years, the PFS and the confidence intervals. So the composite endpoint, which was 1 year local failure rate less than 60%, 1 year progression-free survival, which was more than 60%, and the dose limiting toxicity less than 20% was taken. And the median follow was 30.3 months. And they had decided if all three were met, then the arm, which was numerically superior for 1 year PFS, would be the potential for further study. So what are our take-home messages from these studies? Are these studies practice changing as of today? Answer is no. For nasopharyngeal cancer, we need to understand the compliance of follow-up visits because we cannot explain why there was a difference in DFS when it was not there in the loco-regional and the rates was there in the charts. So we need to know what was the relapse patterns and cause of death in the two arms. There was no OS difference when RT technique is considered. And for locally advanced head and neck cancer in the Pembro group, so Keynote 412, concurrent and maintenance IO and IM VOC 010, which is Atizo in adjuvant setting, is likely to answer. So till that time, they are not standard of care. So this, again, the last interesting study which they had presented, Yometol, plasma tumor tissue, modified viral hepatitis, HPV DNA in NRG HN head and neck 002 study. So they had given two arms were there, the RT versus chemoradiation. They have tried to measure plasma tumor tissue modified viral load at start at T1 at after 2 weeks and end of the study. So maybe in coming days, the tumor biomarkers will help us choose and in predicting who's likely to benefit and which patients we should be escalating the treatment. So the take-home messages from this was, so what are the value implications based on the balance of clinical benefit, toxicity, and cost? We know ctDNA is emerging marker and it is an important predictive biomarker, especially in the assessment of molecular residual disease. Is this study practice changes? We don't know as yet, but yes, TTMV should be included in our HPV-related locally advanced head and neck squamous cell studies. And there are other ctDNA assays should be evaluated, but we know cost is a big challenge and doing in all the patients is not visible. So with this, I'll stop here. Thank you. Handing back to the organizers.
Thank you so much, Dr. Sumit Goyal, sir. Now I would like to invite Dr. Dinesh Pendarkar to present the advances in breast cancer. Dr. Pendarkar is Director Oncology in Sarvodaya Hospital, Faridabad, Chairman of National Cancer Society, past President of ISO and ISMPO. Thank you. Now over to you, sir.
Thank you very much. Thank you, Dr. Ashok, for giving this great opportunity. Can you share the slide or I have to share?
Possible if you can try to share it, sir.
Yeah. I'll try to share. Yeah. So I'm just sharing. I'm extremely sorry for this because can you see the slides?
Sir, still not.
Oh, I put it on.
Yes. Now we can see it.
Okay, so I'll start. So my presentation today relates to highlights of the day of the breast cancer, local, regional, and adjuvant part. So one of the most important trials which was discussed was a Lumina trial. So this was a prospective trial which considered, can we remove radiotherapy from the early breast cancer management? Because we know that whatever we do, radiotherapy does have side effects. So in all patients undergoing conservative surgery, BCS, can in some part of the patient, can we remove this? So this trial was presented from Canada. And the basis of this trial was they selected a special group of patients beyond 55 years of age, T1 in size, T1N0, grade 1 and 2, ER estrogen receptor of more than 1%, PR of more than 20%, HER2 negative, and all patients had undergone breast conservation surgery and had a sentinel lymph node biopsy. And all were started or were to be started on endocrine therapy. So this group of patients underwent Ki67 testing, central testing, and if the Ki67 came as equal to or less than 13.25%, these patients were registered on a trial of no radiotherapy. Other patients were excluded. So they collected basically about 500 patients with luminal A type with specific disease of age beyond 55 and a small size. Ki67 was analyzed centrally. This was really very important point because we know that there are the biggest problem in reporting of Ki67. So this was done deliberately only in 3 centralized labs which had a cross check. And at the end, so what they found out that the cumulative recurrence rate was at the end of 5 years with a median follow-up of more than 5 years was 2.3%. There had been enough literature data available before this, randomized and non-randomized, which had shown that the local recurrence rate, even after radiotherapy, is about 2.8%. So they proved that even if you do not do radiotherapy in this select group of patients, the recurrence rate remains very low, 2.3%. So basically same data, and the overall survival also remains same. So the conclusion was women with age of beyond 55 years, T1N0, G1, G2, luminal A breast cancer, which is ER positive, more than 1%, HER2 negative, and has a Ki67 of less than 13.25%, can be treated with endocrine therapy alone and probably do not require local radiation. So I think that's a great data available, and probably it gives us some thought process to omit radiotherapy in few patients. So the issue was, the basic question mark was, is this 5-year date enough, or should we follow them for more time? But there had been enough data earlier using tamoxifen and radiotherapy, and it was the tamoxifen plus radiotherapy was favored in this trial. But one should realize that what kind of a recurrence we are talking. Are we talking recurrence in the area which was removed, or are we talking of a reference in the same breast or in the opposite breast? So when you realize the recurrence in the area of radiation in the sector which has been removed, there was no difference. So this low risk of recurrence, especially in patients with low Ki 67, was really very, very encouraging. Similar data had been produced by another trials using other parameters, but like oncotype or MammaPrint, and people were able to differentiate different groups between high risk and low risk. So the issue is, which multi-gene assay should we use to find out which patient should go without radiation? And naturally, Lumina has used a very clinically favorable parameter and an investigation profile, which can be done by probably any hospital and really helps us. To find out which patient should go without radiation in favorable parameter. Similarly, there had been another trial which also analyzed oncotype DX data. So when the recurrence score was less than 18, so we know that when the recurrence score is low, the chances of relapse are low. And they had analyzed breast radiation therapy plus endocrine and another data without radiotherapy. Another important presentation which was analyzed in this highlights was in the group of patients with DCIS. So again, the issue with DCIS is when you operate on a DCIS patient, we still are not very sure whether the adjuvant radiotherapy or the adjuvant hormonal therapy benefits the patient. So a new 7-gene biosignature was being developed, which was reported, and it shows that post lumpectomy, DCIS plus tamoxifen. So this was a historical data that there was a difference which favored usage of tamoxifen. This 7-gene biosignature, which was developed, called decision score, it consisted of 7 various biomarkers. This involved 4 countries, and the basic question was, can we, from this biomarker analysis, can we decide some score, or can we use some baseline to differentiate between the patients who would need radiation and who would not need radiation? So the study population was multiple, more than 900 patients. Analysis was performed using predefined DCIS biosignature risk group. So depending on the risk group, whether it was a low risk, DS score less than 2.8, DS score more than 2.8 was an elevated risk, and there was a residual risk. There was a third group called residual risk. So patient distribution in all these groups was 37, 43%, 20%. So when you analyze this chart, you realize that there was no significant reduction in the low risk group. So if you use radiotherapy in a low risk group, there was no significant recurrence reduction. So in the group with elevated risk and residual risk, also there was a slightly increase in the breast events. Similarly, if we use hormone therapy, again, in the low risk group, the events were less. So what this study told, basically the question raised was, do we need radiation in DCIS and do we need endocrine therapy in DCIS? So this is a new way of scoring, like we got score called Oncotype DS or a MAMA print or PALM 70. So basically this is a score, it's a new score of biosignature which is being tried, and it says that if we use this score and if the cutoff point is 2.8, and if you have a low risk group, probably this low risk group based on this biosignature does not require additional treatment. And the third abstract which was discussed here was an important abstract for all of us, which actually compared. So they did produce. So I'll go to the next, which is really important for us. So the important next trial which was discussed was pembrolizumab plus chemotherapy comparison to placebo plus chemotherapy for early stage breast cancer. For early stage triple negative breast cancer, we know that triple negative is a special issue, and the trial was an exploratory analysis from Keynote 522. So what was this trial? So all patients, triple negative breast cancer patients, were randomized 2:1 to receive carboplatin paclitaxel 4 cycles, followed by docetaxel, followed by doxorubicin, epirubicin, cyclophosphamide plus pembrolizumab, and another group similar chemo with placebo. And the survival analysis was done. The number of events in pembro chemo group was 123, and pembro chemo and placebo chemo was 93. So this is a graph which shows that total number of events in the group, pembro group, were 25.5% and placebo 44.3%, with a hazard ratio of 0.52, suggesting that addition of pembrolizumab in neoadjuvant setting in TNBC does reduce the event-free survival. So addition of pembrolizumab resulted in event-free survival improvement in basically the categories which was RCB 0, 1, and 2. The small subset of patients with extensive residual disease. So what is meant by RCB 0, B1, and B2? So when you do neoadjuvant chemotherapy and then you perform the surgery, so what was the residual disease remaining? If the residual disease was 0, classified as 0, then the EFS was much better. If there was an extensive residual disease in both the treatment arms, there was a poor prognosis. So irrespective of, so addition of pembrolizumab in patients who have a lot of residual disease does not help in improving the event-free survival. What does this mean for us? This means for us that even if you are using an immunotherapy in TNBC, we still do not know how the patients are likely to benefit. And so patients who have a remaining disease at the end of surgery, so neoadjuvant chemo, surgery, lot of residual disease, we still do not know how to manage this group. If there is a very good complete response post-surgery, complete pathological response, addition of pembrolizumab may help. But if there's a lot of residual disease, even addition of pembrolizumab may not help. So it's an open question. I think I would like to stop here. Thank you.
Thank you so much, Dr. Dinesh sir. Now I would like to invite Dr. Jyoti Wadhwa to present the advances in lung cancer. Dr. Jyoti Wadhwa is the Director of Medical Oncology, Medanta, the Medicity Hospital. Thank you. Over to you, ma'am.
Good evening, everyone. Let me share my screen. Are my slides visible?
Yes, ma'am.
Okay. Okay, so I'll be presenting 4 papers which were presented in the recently concluded ASCO 22 relating to lung cancer. They relate to different aspects of treatment of lung cancer, non-small cell lung cancer, small cell lung cancer, role of immunotherapy in both these histologies, and also very interesting data on the quality outcome and the radiation. So let me start with the first one. The first one evaluated the role of addition of nivolumab as the immunotherapeutic agent to chemotherapy in resectable stage 3A and B non-small cell lung cancer. This was the NADIM-2 trial. The patients who had, as per 8th edition AGCC, locally advanced potentially resectable stage 3A or B non-small cell lung cancer were randomized 2:1 to receive either nivolumab with paclitaxel and carboplatin for 3 cycles given every 3 weekly, or they received only chemotherapy with paclitaxel and carboplatin every 3 weeks. Now, 3 cycles of either of these two were followed by surgery, and if they had R0 resection, this was followed by adjuvant treatment administered for 6 months. The patients were then followed up for 5 years. The primary endpoint of this trial was the pathological CR, which is defined as absence of any viable tumor cell in the resected lung specimen and all the resected regional lymph nodes. Now we know that there is a strong association between attainment of PathCR and survival following neoadjuvant therapy, and this has been proven in some other cancers as well, most notably in breast cancer. However, in lung cancer and non-small cell lung cancer, the PathCR with neoadjuvant chemo alone has been quite low, to the tune of 0 to 16% only. So this trial aimed to look at any possible additional benefit or improvement in the PathCR rates after the addition of immunotherapy in form of nivolumab to the standard chemotherapy. This trial had the power, 80% power, to detect any improvement in the PathCR to the up to the rate of 40%. Now, interesting results. The PathCR rates in the nivo with chemo arm were 36.8%, whereas they were only 6.9% in the chemo alone arm. The overall response rates were also much higher, to the tune of 75% with the nivo with chemo arm compared to 48% in the chemo alone arm. So stark difference here, marked improvement in the PathCR rates with addition of nivolumab to paclitaxel and carboplatin. Interestingly, there was an association seen with the biomarker, the known biomarker, which is PD-L1. So the patients who achieved PathCR had in fact higher PD-L1 expression than patients who did not achieve PathCR. The PathCR rates also were raised across increasing categories of PD-L1 TPS score. So if the score was less than 1%, then the PathCR rates were 15%. If they were 1 to 49%, the PathCR rates increased to 41.7%. And if the PD-L1 TPS was 50% or greater, PathCRs were as high as 61%. So very interesting association reported there in this trial. Now, there are other studies also, and there are many phase 3 trials which are still ongoing, looking at the role of neoadjuvant chemo with anti-PD-1 or PD-L1 antibody therapy in lung cancer, non-small cell lung cancer. Most notable amongst them is the Checkmate 816, results of which have been reported, and it has already got the US FDA approval. Now, this was a little different because the stages included in this Checkmate 816 trial were patients who were stage 1B, stage 2, and stage 3 resectable disease, compared to the Nadim 2 trial, which included only stage 3 resectable patients. Checkmate 816 used the 7th edition AJCC classification. It was phase 3 trial, and the patients in this trial received nivolumab as well as histology-based chemotherapy. So if you notice here, the top row, the patients received 3 cycles of either cis-PEM or carbopecli gem, or so whether it was adeno and the patient went on to receive PEM-based treatment, or whether the patient had squamous and received taxane with platinum, or the patient could have received gemcitabine, cisplatin, or carboplatin. So the chemo was variable and was based on the histology, but nivolumab was combined with the chosen chemotherapy. And this reported the results with improvement in the PATH-CR rates for stage 3 from 1% with chemo alone to 23% PATH-CR rates with addition of nivolumab to the histology-based chemotherapy. And I've already presented the data in the Nadim 2 trial. So take-home points from this trial is that the patients with resectable stage 1B to 3 non-small cell lung cancer, neoadjuvant nivolumab with histology-based chemotherapy is in fact now one of the available FDA-approved approaches. And patients, in fact, who have resectable stage 3 and a high or higher PD-L1 score may be, in fact, the best suitable candidates for getting neoadjuvant immuno with chemotherapy. The molecular profiling of, therefore, the earlier stage non-small cell lung cancer is now becoming increasingly necessary. So very interesting results, very important, relevant data there. Moving on to the second abstract, the intraoperative quality metrics and association with survival following lung cancer resection. So this is also very pertinent. The surgical quality metrics in non-small cell lung cancer, which were included in this study, were the timeliness of surgery, whether within 12 weeks of radiographic diagnosis or later, whether the patient underwent anatomic dissection, whether it was lobectomy or segmentectomy, what was the approach, how invasive was the approach, whether it was minimally invasive or open approach, what was the adequacy of nodal sampling, so at least 10 lymph nodes are said to be standard, and what was the status of the margins, whether it was negative or positive surgical margin. So based on these 5 quality metrics, a score was developed. So as I mentioned, surgery, whether it was within 12 weeks or more than 12 weeks of diagnosis, whether it was open or minimally invasive surgical approach, the extent of resection, whether it was just lobectomy or pneumonectomy, the nodal sampling adequacy, whether it was none or 1 to 4, 5 to 9 nodes, or 10 or more lymph nodes which were sampled on surgery, and whether it was R0 or R1 resection, a score was given. And the patients who underwent surgery for clinical stage 1 non-small cell lung cancer between 2006 to 2016 were included in this analysis for the 5 quality metrics as I just enumerated, and the data was then analyzed. Very interesting data. The association of the score with overall survival and recurrence-free survival was studied. The higher the score, the better was the overall survival and better was the recurrence-free survival. So this is the breakup in terms of number of patients regarding different quality metrics, quite significant number in each category. And this proved that adherence to good surgical principles does improve the overall survival. And in fact, if these principles are applied uniformly throughout the country, this could lead to many years of extended life for patients with stage 1 non-small cell lung cancer, and a real good cure could be achieved. And for obvious reasons, as we already know, the significance of achieving negative margin, this had in fact the highest impact in this scoring model as well. And adequate nodal sampling and extent of resection were also an important component of this model. So another important abstract. Coming to the third one, the Skyscraper 02 trial, a randomized double-blind placebo-controlled study of tiragolumab with atezolizumab plus chemotherapy in patients with untreated extensive stage small cell lung cancer. So we know that atezolizumab or durvalumab, when added to chemotherapy for treatment of extensive stage small cell lung cancer, they have resulted in improvements in the overall survival. In fact, for the first time, the patients were living beyond 12 months. So this study looked at whether the addition of tiragolumab, another monoclonal antibody, to the current standard of atezo with chemo made any difference. So patients in good performance status, PS 0 or 1 with measurable disease, and they had to be treatment naive. They were included and randomized 1:1 to receive either tiragolumab with atezo with etocarbo, all given every 3 weeks, or placebo with atezo with etocarbo given every 3 weeks. This was followed after the initial 4 cycles with the maintenance, as is the current standard. The arm 1 received maintenance with both tiragolumab and atezolizumab, whereas the arm 2 received placebo with atezolizumab, and they were treated until progression or unacceptable toxicity. The progression-free survival and the interim OS have been reported. The median PFS was 5.1 months in the tirago with atezo chemo arm and was 5.4 in the atezo with chemo arm, with hazard ratio of 1, no improvement there. And also for interim overall survival, there was no statistical improvement reported with the addition of tiragolumab to atezo with chemo. The patients, the subgroup of patients who had brain metastasis, the median was 11.7 months versus 10.6 months in the atezo with chemo arm, hazard ratio of 0.92. So the triplet of platinum with ETO with either atezo as per the IMPAR 133 or durvalumab as per Caspian data remains the current standard of care for the first-line treatment of patients with extensive stage small cell lung cancer. And the addition of tiragolumab did not make any significant difference to the current standard of care. However, there are other agents which are being studied for treatment of extensive stage small cell lung cancer. Coming to the fourth and the last abstract, comparison of quality of life in patients randomized to high dose once daily thoracic radiotherapy with the standard twice daily thoracic radiotherapy in limited stage small cell lung cancer. And this was a CalGB study. The patients with limited stage small cell lung cancer, we know that radiotherapy with chemotherapy, concurrent chemo, is the current standard of care. The BID thoracic radiotherapy to 45 Gray is superior to once daily thoracic radiotherapy, again to the dose of 45 Gray. And both went on to receive concurrent chemo with etoposide cisplatin. The median in the BD thoracic radiotherapy has been reported to be 23 months, the median OS, versus 19 months in the once a day dosing of thoracic radiotherapy. And the 70 Gray once daily thoracic radiation was not found to be superior to the lower dose 45 Gray. And that's how 45 Gray was the standard. The median OS was 30.5 months versus 28.7 months in the BD. And in this study, no difference was reported in terms of toxicity between these two arms. Now, the hypothesis for this study was that given the equivalence in efficacy, the differences in quality of life scale measurements could help the clinician choose between either of these regimes. So which was better, in fact, BD or OD thoracic radiation routes? The patients were administered the standard quality of life scales, and patients were also asked to assess treatment inconvenience at multiple time points during the study. So it was noted in this study that the quality of life worsening was less for the QD arm at week 3 and more for the QD arm at week 12. Now, what were the side effects? The significant ones were acute esophagitis, difficulty in swallowing, and they were significantly worse in the BID arm at week 3, as is evident here in the curves. So both QD and BID radiation regimes had similar efficacy outcomes. The QD arm had better quality of life scores at week 3, and QD arm was perceived to be less inconvenient. The BID arm had better quality of life scores at later week 12, and choice of radiation would have to be made, therefore, after a detailed discussion with the patient, taking into consideration the logistical factors and the depth and duration of potential side effects and its impact on quality of life. So this was the take home from this study. And so that ends my 4 abstracts. And thank you very much, Dr. Ved, for giving me this opportunity.
Thank you so much, Dr. Jyoti ma'am. It was an amazing session. Now, I would like to invite Dr. Nagendra Sharma to present advances in genitourinary cancer, kidney and bladder. Dr. Nagendra Sharma, consultant, Department of Medical Oncology and Hematology, Medanta Cancer Institute, Gurugram. Thank you, and over to you, sir.
Thank you very much. Yeah. So to the point, the fourth presentation today, given to me with the ESCO highlight genitourinary cancer tract. So I'll be presenting what were the abstracts which were published in last couple of months.
Hello, Dr. Nagendra.
Yes, sir.
Sir, we cannot see your slides in the full screen, sir.
Can you see it now, sir?
Still not, sir, in a full screen.
Once again.
Just stop share and reshare it again, sir.
Okay, I will stop it and I will reshare it.
Yeah.
Can you see it now?
Sir, still not. We cannot see it.
Hello. Can you see this right now, sir?
Sir, still not, sir. The slide got stop share.
Just give me a moment. I think it's visible right now.
No, sir. Should I share it, sir?
Please share it, sir. I think
Yeah.
there's some interactive issue. So,
You will be sharing, sir, or should I?
you can share it, sir. Not an issue.
Yes, sir.
I will stop it now.
You can go ahead, sir.
Hello. I can see the slides right now.
Yeah, you can go ahead, sir.
Just 1 second. The slides are visible right now, sir.
So still not. Should I share it, sir? Mine?
I think there's some connectivity issue probably.
Sir, there is some internet issue at your end, sir.
I'm sharing. You can share it from your side.
Sir, you can continue, sir.
Okay. So, but I can't see the slide, sir. Only point here is, just give me a moment. I'm just opening. Just give me a moment. I'm sorry for the technical glitch. It's visible right now, sir. I can see it now.
Sir, I have shared
Hello?
the slides. You can go ahead with the talk, sir.
Okay. So the topic given to me is cell-free DNA methylation as a predictive biomarker of response to neoadjuvant chemotherapy for patients with muscle-invasive bladder cancer in SWOG S1314 study. So this is the first abstract which was published in ASCO. The second abstract is association between the depth of response and clinical outcomes. This is exploratory analysis in patients with previously untreated advanced RCC in Checkmate 9ER study. This is also interesting and relevant abstract which was published. Other one is the relationship between the health-related quality of life and clinical outcomes in the patients with advanced RCC in Checkmate 214 trial. The fourth abstract which was published was cabozantinib in combination with rituximab in urothelial carcinoma. Results from cohort 3, cohort 4, and cohort 5 of the COSMIC 021 study. The first abstract was the S1314 cell-free DNA methylation as a predictive biomarker of response to neoadjuvant chemotherapy for patients with muscle-invasive bladder cancer. The hypothesis of this exploratory TM hypothesis was that cell-free DNA methylation patterns can predict the response to neoadjuvant chemotherapy in muscle-invasive bladder cancer. So the SWOG S1314 evaluated the co-expression extrapolation score as a predictor of neoadjuvant chemotherapy response in muscle-invasive bladder cancer. So in this, prospectively, they collected a plasma from the subset of patients before cycle 1, that is pre-treatment, and cycle 2, that is on treatment. So all the clinical stage from C, T2, T4A, N0, M0, urothelial carcinoma were planned for cystectomy. They were randomized in arm A and arm 2. In arm A, yes, sir?
Sir, we cannot see your slides still, sir, because there is a internet connectivity issue. A lot of time you are stuck in between, sir. So if you can stop your video and share the slides and continue the talk, sir, like that.
Okay, I will do that. Now it's visible, sir? Hello?
The screen sharing is coming. The slides are not visible, sir. If you allow me to share the slides, so I will share it, sir.
Please do that, sir. I'm stopping sharing.
This slide will be on, or the next slide, sir?
Now it's visible now, right? Right. Thank you. So this was a study in which stage 2, CT2, T4, N0, M0, urothelial carcinoma were planned for cystectomy. They are randomized to arm A and arm 2. In arm A, there was gemcitabine and cisplatin, 2-3 weekly, 4 cycles with growth factor support wherever it was deemed appropriate. And in arm 2, they have used dose-dense methotrexate, vinblastine, doxorubicin, and cisplatin. That is dose-dense MVAC, 4 cycles with mandatory growth factor support. And then after that, they have looked into the samples. Next slide, please. So the machine learning predictive biomarker, that MR scoring was done. MR scoring means that methylation-based neoadjuvant chemotherapy response score was assessed. So there was no single methylation locus statistically correlated with the response after adjustment for multiple comparisons. And however, SNA mapping responders means who are having a CR or partial response, and non-responders means those who are not having response to this strategy. So they were clustered separately based on 500 most differentially methylated DNA loci. So therefore, we applied a random forest machine learning and leave one out cross validation to all 850,000 loci to create a methylation-based neoadjuvant chemotherapy response score, that is MR scoring. So in which they have categorized those who are having response and those who are not having response on this platform. Next slide, please. So circulating bladder DNA analysis was done. The tissue source of cell-free DNA can be assigned using previously at-lasted tissue methylation profiles. The circulating bladder DNA levels correlated with the depth of response, and circulating bladder DNA levels and MR score were independent of one another. So this is what is typically depicted in this graph, that on the they have compared those patients who are having CR, PR, or not responder, and they have measured the circulating bladder DNA percentage, and they have found out very clearly that those patients who are not having response, they can figure it out whether to go ahead with surgery upfront or whether to expose the chemotherapy those who are having response initially only. Next slide, please. So MIBC risk stratification model was performed, and 57 patients with pre-treatment and on-treatment plasma were stratified. The risk stratification was pre-treatment MR score and pre-treatment circulating bladder DNA. So they were categorized into 3 categories, that is high risk, intermediate, and low risk. So 10 out of 12 patients are not responders, 18 out of 22 patients were responders, and risk stratification was done on the on-treatment MR scoring. So what they have found out, that those patients who are having a high risk, they have gone, that was 7 out of 8 patients were not responding in the intermediate and high risk, and in very low risk, 10 out of 15 patients were responders. So 45 out of 57 patients, that is 79%, were correctly classified by this model. Next slide, please. So in senior methylation, APIC bead chip array was done for cell-free DNA methylome analysis. It is cost effective, is around $260 US per sample, and is commercially available also. The standard established analysis tools were performed. However, it used extensively for the tissue profiling, but not previously tested for the cell-free DNA, lower DNA content. The cell-free DNA methylation provides profiles from the same healthy donor clustered together and consider data even at the low cell-free DNA input quantity, as you can see in this slide. Next slide, please. So is this trial practice changing? Answer is no, not yet. Requires a validation in the larger number. So does the depth of response translate into meaningful endpoint? The quality of pathological response and surgery correlate with the survival of the patient with completely resected bladder cancer after neoadjuvant chemotherapy, and the impact of pathological response to the neoadjuvant chemotherapy on the conditional survival among the patient with muscle-invasive bladder cancer, and the correlation of the pathological complete response with survival after neoadjuvant chemotherapy in bladder cancer treatment treated with the cystectomy. It was a meta-analysis. So what is the take-home points from this message, from this abstract, was that it is a potentially future low-cost clinical assay which could be used to at least separate responders from non-responders, and is cost-effective around just $260 per sample. A non-responder might go right to the surgery if the baseline sample indicated a poor response to this chemotherapy regimen. So by initially only, if we are able to figure it out, that this patient is a responder or not responder by this platform, we can decide whether to go ahead directly with the surgery for this patient or this subset of patients, or we should go ahead with the neoadjuvant approach and to diversify the treatment and go ahead with the surgery after completion of chemotherapy in the responder patient. Next slide, please. So obviously, the potential greater applicability of this is only in the metastatic setting, that higher cell-free DNA and higher circulating tumor DNA content is available on the tumor tissue is not readily available majority of the time, and it reflects the total circulating methylome, that is cell-free DNA, not just somatic circulating DNA. It's potentially utility to other therapies also. Immune checkpoint inhibitor also have to be linked to. So it is a first step in right direction, and it is translational potential, and it is a baseline for the future study. Next slide, please. So next study was association between the depth of response and the clinical outcomes, which was exploratory analysis in the second abstract which was published in the previously untreated patients of advanced RCC in the Checkmate 9ER study, which is Neo-Cabo study. So what is that? In this study, the inclusion criteria was those patients who are previously untreated advanced or metastatic RCC who are having clear cell component or any IMDC risk group. They were stratified based on the IMDC risk score, tumor PD-L1 expression, and geographical region. It is 1:1 randomization in which nivolumab was used at the 240 milligram IV Q2 weekly, and cabozantinib was used at 40 milligram per orally once a day. It was compared hand-on with standard of care as sunitinib, 50 milligram per orally once a day, 4 weeks on and 2 weeks off schedule, and both the arms were equally balanced. And the primary endpoint of this trial was median PFS by blended independent central review. A RECIST 1.1 criteria was taken into consideration for radiological assessment. secondary endpoint was overall survival, objective response rate by blinded independent central review, and safety outcome. So patients were treated until the defined progression or unacceptable toxicity. Next slide, please. So the depth of response analysis was done, and this exploratory analysis included patients with baseline and available post-baseline best overall response rates. Patients were categorized into depth of response subgroups based on the best overall response and best tumor reduction threshold as follows. So the CR is complete response. The PR1 is PR response with best reduction in sum of diameters of target lesion greater than or equal to 80%. PR2 was PR with best percent reduction in sum of diameters of target lesion greater than 60 and less than 80%. PR3 is partial response with best percentage reduction in the sum of diameters of target lesion less than 60% of the patient. SD and stable disease, and PD is progressive disease. For each depth of response subgroup, the following endpoints were analyzed. The PFS OS after a 6-month post-randomization landmark, that is time 0, in patients who were alive, and progression-free survival and overall survival was also taken as a landmark. Time to end duration of objective response were analyzed, and treatment-related adverse events within 30 days from the 6-month landmark from analysis of overall survival was taken into consideration. Next slide, please. So IMDC prognostic risk was also stratification was taken into consideration for assessing the depth of response, and all were analyzed. So IMDC, a prognostic risk group, was generally similar between the treatment arms within the subgroups, with the exception of CR and PR1 subgroup. You can see clearly. So those patients who are having favorable, intermediate, and poor risk as far as IMDC prognostic group, they were analyzed, or those who have got CR, PR1, PR2, PR3 as stable disease and progressive disease. It was matching in all except in the CR and PR1 subgroups. Next slide, please. So 18 months overall survival rates by depth of response subgroups was analyzed, and there was an increasingly deeper response led to a better overall survival outcome, as you can see clearly with Nivo-Cabo. So there are 37.9% of patients have got CR, PR1 or PR2, and remaining have got PR3 or stable disease. Only 14 patients out of the patients who are enrolled have got a progressive disease. And only 17.1% of patients with sunitinib have got a CR, PR1 and PR2. This is favoring Nivo-Cabo at 18 months overall survival. That's the results were translated into overall survival outcome. Next slide, please. So time to and duration of objective response rate, the median time to response for CR is 2.8 months, so PR1 is 2.8, and PR2 also is 2.8. Really, it is hovering around 2.8. But as you can see in sunitinib, it is above 3.4 to 3.5, and PR3 it is 5.7 months. And median duration of response also have not yet reached in the CR group, and it is 26.2 months in PR1 and nearly 10.8 months in the PR3. But as you can see in the sunitinib, it is much. So, next slide, please. Mr. Nirav, can you do the slide sharing? Mr. Nirav?
Yes, sir. I'm moving the slides. Can you continue, sir?
Okay, it's not visible. Can you do that once again? Okay, I will continue then. Right. So this was the study which have shown us the depth of responses as far as time duration is concerned. So treatment-related adverse events by depth of response also was far better for Nivo-Cabo studies. The incidence of any grade or grade 3-4 treatment-related adverse events was generally constant across the depth of response group. Next slide, please. To conclude, the take-home points is it is a post-hoc analysis, and IMDC risk in this setting did not translate into overall survival, which is interesting. And does the depth of response translate into meaningful endpoint? It is questionable. Next slide, please. The next is the relationship. The third aspect was the relationship between the health-related quality of life and clinical outcomes in the patients with advanced RCC in Checkmate 214 trial. So it was treatment-naive clear cell advanced RCC and measurable who are having a measurable disease and KPI score of greater than 70%, and treatment-naive clear cell advanced RCC. It is 1:1 randomization, and Nivo-Ipi was compared with sunitinib. So health-related quality of life is the exploratory endpoint, including FKSI 19 total score and FKSI 19 DRS score. So the FKSI 19 score means Functional Assessment of Cancer Treatment Kidney Symptom Index, and the DRS score is basically total score and the disease-related symptom burden. Right. Next slide, please. So FKSI 19 instrument have taken into consideration the disease-related symptoms, treatment side effects, and functional well-being and emotional status also. So all this were taken into consideration, and cycle 1, cycle 2, cycle 3, and beyond, they were checked at day 1 and week 1, and day 1, week 1, 4, and hands-on and 4. So all this were analyzed in this, and the objective of this was that they have checked for the baseline health-related quality of life. Next slide, please. And PFS, and longitudinal health-related quality of life and PFS. The analysis uses 5-year follow-up data of intermediate and poor risk advanced RCC patients from CheckMate 214 trial to assess the following decision. The baseline health-related quality of life refers to data collected pre-treatment and at randomization, and longitudinal health-related quality of life refers to health-related quality of life data collected after randomization while on study. The health-related quality of life was assessed using a functional assessment of cancer therapy kidney symptom index, FKSI 19, total score, and disease-related symptom physical index. Next slide, please. The landmark analysis, the overall survival by FKSI 19 total score response at 6 months was assessed, and this is a Kaplan-Meier curve which is showing that those patients who are having health-related quality of life responders, the median overall survival was much better. That is 67.8 months, vis-a-vis 32.0 months in health-related quality of life non-responders. The hazard ratio was 0.47, favoring the health-related quality of life in responders. As you can see, the Kaplan-Meier curve, they are wide apart. Next slide, please. To conclude that the take-home point was it was somewhat intuitive. Is it practice changing? Answer is the quality of life was previously validated outcomes, and it was indeed useful. It is outside of clinical trial. Patient-related outcomes are hard to enforce, and individual caring of the patient side effects can be helpful, although time spent with EMR can affect the thoroughness of the questioning. The last abstract was COSMIC 021 for urothelial carcinoma in cohort 3, 4, and 5. These are published by Paul et al. Majority of them were Indian authors. The key eligibility criteria of this trial was inoperable locally advanced metastatic urothelial cancer with translational cell cytology and ECOG performance status 0. Cohort 3, in which no prior systemic treatment who are cisplatin ineligible. Cohort 4, who are having no prior systemic treatment with cisplatin eligible. Cohort 5, one prior immune checkpoint inhibitor and no prior VEGF TKI therapies or less than equal to 2 lines. And cabozantinib plus atezolizumab was combined. Cabozantinib was used at 40 mg once daily. Atezolizumab standard dose of 1,200 mg Q3 weekly intravenously. And primary endpoint of this trial was objective response rate. Secondary endpoints were safety, and exploratory endpoints were duration of response, PFS as reached 1.1 by investigator and overall survival. Next slide, please. So disposition, exposure, and safety was performed, and they have checked for all these cohorts, and they found that the discontinuation because of treatment-related adverse events were more with cisplatin eligible in cohort 4 as compared to those patients who have been exposed to other cohorts like of cisplatin ineligible or who have been exposed to prior immune checkpoint inhibitor, as you can see clearly in this graph. Next slide, please. The tumor response as per investigator raised 1.1 criteria. The objective response rate was 20 in cisplatin ineligible. That is cohort 3. Cohort 4 it was 30. In cohort 5 it was 10. And disease control rate in which combined PR, and stable disease were taken into consideration was 80 with the cohort 3, that is cisplatin ineligible. It was 63 with cohort 4, that is cisplatin eligible, and cohort 5 it was received prior immune checkpoint inhibitor. The duration of response was 7.1 months. For cohort 3, it was not evaluable for cohort 4, and for cohort 5, it was 4.1 months. Next slide, please. Survival is cisplatin eligible. As you can see clearly, it was 14.1, and the cohort 4 it was 30.5 months. And median overall survival in cohort 5, that the patient who have received prior immune checkpoint inhibitors, was 8.2 months. So this is favoring those patients who are having cisplatin ineligibility. They have got a better median overall survival as compared to other subgroups. To conclude, is it a practice-changing trial? So atezolizumab alone group had CR of 6%, PR of 17%, overall survival of 15.2 months in atezolizumab group, combined platinum eligible in children, and it was 16% with grade 3 and higher grade serious adverse events and 6% with discontinuation rate. So what was considered as cabozantinib is toxic in this subgroup, and some patients have got a response compared to the denosumab alone. So it is difficult to assess. It is difficult to assess the overall level without knowing the subsequent therapies in this trial. So I think I have come to the end of this presentation. Thank you very much for patiently listening.
Thank you so much, Dr. Nagendra sir. Now, I would like to invite Dr. S.P. Kataria to give vote of thanks. Dr. S.P. Kataria is Vice Chairman, Medical and Hemato-Oncology, Medanta, the Medicity, Gurugram. Thank you, and over to you, Dr. S.P. Kataria, sir.
Good evening, sir. Thank you very much, Dr. Ashok Ved, sir. Thank you very much, Dr. Rajesh ji, for me being part of the meeting today. It's been a wonderful day. We had a lot of new experiences from the current, very recent ASCO meeting in 2022. So my job today is just to summarize what we discussed today. Initially, as you have seen, I remember from the time of 60s and 70s when we used to have only surgery as the treatment of choice for all cancers. Subsequently, 80s and 90s, we had chemotherapy, and we reached the peak in around 2000 with paclitaxel and a few other chemotherapy drugs. Usually, it used to be one drug a decade at that time. Gradually, with our TKIs and our IOs, it improved to once a year. We used to have one new drug every year almost till 2010, 2015. And for last 3-4 years, we are having almost 10 new drugs in immuno-oncology and targeted agents that are available every year for our cancer patients. I think the times are exciting. We have had 5 speakers actually today. We had Dr. Ashok Ved, who gave us an insight into the new work that is going on. We had the small molecule for as a P53 reactivator. We know that P53 is a widespread mutation in most of the cancers, especially even at the earlier stage. Subsequently, we also had the seribantinib, DS609, and CBP1008, a bispecific ligand for treatment of solid tumors. Things have improved quite a bit. I mean, of course, they are still experimental, phase 1, phase 2, but they will be there in phase 3 and ultimately in clinical practice soon. Subsequently, we had Dr. Sumit Goyal, who presented us the newest abstracts in the head and neck cancer, trying to reduce the toxicity of the chemotherapy by rescheduling the chemotherapy drugs or omitting the chemotherapy altogether. We had the high dose cisplatin versus low dose cisplatin abstract, one of them especially from our own AIMS, Dr. Atul Sharma. We also had the abstract for chemotherapy addition with nimotuzumab and concurrent chemoradiotherapy, which showed a statistically significant improvement in response rates and also overall survival in head and neck cancers. Subsequently, we had the Keynote 412 study that was concurrent versus sequential pembrolizumab plus concurrent chemoradiotherapy, and it showed that there was a better response rates in these patients. This was followed by Dr. Dinesh Pandakar. He presented us 4 abstracts in breast cancer. The first one was the Lumina trial that presented in very low risk luminal A patients above 55 years of age, T1A1N0 disease, who could be given breast conserving surgery and in whom the breast radiotherapy could be omitted. and they showed that there was no significant difference in the local recurrence rates in these patients. 2.3 versus 2.8%, not a very significant difference. Secondly, in the low risk, how to stratify low risk, they use the multi-gene assay, especially Oncotype DX in the study of NRG BR007. Similarly, another marker they used was the DCIS biosignature, which we identified the low risk group as less than 0.28 score. And the fourth study was the neoadjuvant pembrolizumab chemotherapy, the keynote 522 in TNBC, which showed that there is an improvement in EFS and pathological CR in these patients. Next, we had our director at Medanta, Dr. Jyoti Vadva. She presented nivolumab plus chemotherapy as neoadjuvant chemotherapy in advanced stage 3 and 3A and 3B lung cancer, and showed that addition of neoadjuvant immunotherapy to standard chemotherapy arm improved pathological CR rate and overall survival in these patients. We also had another abstract that looked at the surgical quality of the surgical treatment, which included timely surgery, anatomical resection, adequate nodal sampling, surgical margins, and the surgical approach, whether it is minimal or open thoracic surgery. And they showed that higher the score, it resulted in better overall survival for these patients subsequently. She also showed that addition of another immunodrug to atezolizumab in advanced lung cancer did not improve the response rates or the overall survival or PFS in patients with lung cancer. Fourth abstract was the quality of life, that is giving high dose radiotherapy once daily, high dose thoracic radiotherapy once daily or twice daily, did improve response rates in these patients, but the quality of life parameters were similar in both groups. Dr. Nagendra Sharma had presented 4 abstracts in the kidney and the genitourinary system. One was cell-free DNA methylation as a predictive biomarker. Second study was the depth of response to immunotherapy and targeted therapy, that is Nivo plus cabozantinib as compared to Sutent alone. And they showed that Nivo and Cabo was better. Quality of life in Checkmate 4214 study with Nivo plus EP was versus Sutent, and they said that quality of life parameters were similar in both groups. Similarly, the fourth abstract of Cosmic study 021 in transitional cell type of urothelial cancer, they showed that cabozantinib plus atezolizumab in cisplatin ineligible and eligible patients did better than patients who were already received immuno-oncology drugs. With this, I think I will summarize that immuno-oncology has come here to stay, from palliative care to adjuvant setting, and now we are getting it into the new adjuvant setting in a more of a standard clinical practice guidelines. I hope it continues and our patients continue to improve further. Thank you. Over to Dr. Ashok Vaid.
Thank you, Dr. S.P. Kataria, for that wonderful summary and giving us an overview of the proceedings this evening. And I thank everyone on the program for taking out time. There is a question in the question box from Mona Grain. In case of carcinoma in situ hormone receptor positive and HER2/3 positive, what is the plan of management? So HR positive and HER2 new positive in situ. So anybody would like to take that question before we close the session? SP, you would like to take, Dr. Jyoti or anybody?
No, what was the thing? It is
hormone receptor positive in situ HER2 new positive. It's not an invasive. It's an
it's not an invasive cancer. So we really, I don't know whether we should be doing the ERPR or HER2 testing in these patients or not. That's one thing.
So plan of management. The question
I
is,
don't know whether we are changing any practice.
Right. So there is no role for HER2 new directed therapy. That is the question which is being asked. So there is no role for that. So with that, we come to the end of the proceedings this evening, and it's been a wonderful learning session. I think Rajesh, if you have something to say, or Om Mishra from Samarth, Om, you have something to say before we close the session?
Sir, it was really a wonderful session, but we'll like to take this session into a next level so that your fraternity, young budding oncologists, should be benefited with your experience and with your knowledge. So only this was slightly missing, and we'll take this up into next classes. And thank you for providing us an opportunity to be part of your master classes.
Point is well taken. The format for this evening was purely focused on the ASCO, the
Yes, sir.
abstracts
Yes,
and the ASCO presentations. Sure, we will have a different format next time. Rajesh, anything from your side? I think Rajesh.
Nothing, sir.
Nothing. Thank you so much, ladies and gentlemen, and greetings on the day, on the occasion of the Doctor's Day to everyone. And thank you so much.
Yes, sir.
We close
Thank you,
the
sir.
session.
Thank you.
Thank you so much.
Thank you, sir.